Started. Okay, so welcome everyone again to our cardiac CT and MRI lecture series. Today we have the pleasure of having Dr. Armin Zadeh from Johns Hopkins University. Dr. Zadeh is originally from Germany. He's now the director of cardiac CT at Johns Hopkins and an associate professor of medicine at Hopkins as well. He has published over 100 papers and has multiple publications on cardiac CT, but also multiple on the concept of a vulnerable plaque and the vulnerable patient. He's going to be talking to us today about the myth of the vulnerable plaque. So please, if you have questions, put them in the Q&A chat, and we'll go over them at the end. Thank you for being with us.
Well, thank you, Leandro. It's really a pleasure to be here. Thank you for inviting me and to talk about the vulnerable plaque, which always creates discussions. My disclosures, I do have research support from Canon Medical Systems to study the diagnostic utility of ultra high resolution CT, which may be applicable here. So the objectives are shown here. I also should mention as a disclosure, it's much more exciting to talk about something, a new concept in a positive way instead of poking holes in a concept, which is creating a lot of excitement. So I don't enjoy being the spoiler, honestly, but at the same time, it's obviously part of the academic process and research that we critically review data. So I hope this is not, coming out too negative, but rather I hope you take something away from this discussion, particularly when we talk later a little bit about the practical implications of this kind of research. Okay, so let me start with an editorial by Steve Nissen, which came out in JACC just a few months ago. So Stephen was asked to comment on a paper which used essentially preemptive stenting in vulnerable plaques. So lipid-rich plaques versus non-lipid-rich plaques identified by infrared spectroscopy. So, and as you can see, the title of this editorial was Vulnerable Plaque and Einstein's Definition of Insanity. So he was inferring that, to the quote often attributed to Einstein, that doing something over and over and over and expecting different results, is insane. Only Steve Nissen can put things as poignant as he did in this editorial, and I just want to quote some of his editorial here. So for one, he says, it seems abundantly clear that the entire concept of vulnerable plaque is fundamentally flawed and reflects an overly simplistic view of the pathophysiology underlying coronary events. He further goes on to say, to date, proponents of vulnerable plaque imaging have not conducted high-quality trials, and no imaging modality has demonstrated a meaningful clinical benefit. And then lastly, after thousands of vulnerable plaque papers and more than 2 decades of research, we have little to show for these efforts. And sometimes, when maybe even often, I disagree with Steve Nissen, but in this context, I think he's right on the money. The only thing I was disappointed about was that he did not quote us. So because many of these statements actually we put we published years ago, almost ad verbatim. But if that's true, if you assume this is true, the big question, of course, is, so why will the vulnerable plaque story not die? And what is the vulnerable plaque story? Just in a nutshell, it's the assumption that if you do something to a plaque which is prone to rupture or erode, that will prevent myocardial infarctions. It's a given that most acute coronary syndromes do arise from a plaque rupture erosion. So then the assumption is if you identify these plaques, do something to them and keep them from rupturing, maybe you can prevent events. And it's a compelling story. And I don't know why it's not going to die for sure, but I assume it has something to do with the fact that we all kind of craving for an easy fix solution. And I was thinking of the analogy of weight loss, that we, there's so many Americans, the majority of Americans struggle with being overweight, and the solution is very simple. We have to reduce our calorie intake, but it's easy and it's cheap. But we're craving for a much easier solution, and spending, in fact, billions of dollars every year just to come up with a easy fix solution. So there is something inherently human in there, just to have the desire to have an easy fix, and I think that applies to the vulnerable plaque concept as well. And in fact, there is considerably business interest in the vulnerable plaque. Many of technology, particularly invasive technology, arose, based on that concept, identifying this vulnerable plaque. There's IVIS virtual histology, OCT, infrared spectroscopy, and then there's some technologies which kind of were on vogue for a while, and then it disappeared, like thermography. Many of you may not even know what that is. It was an invasive technique which detected with fine sensors the temperature changes in the plaque, and so very highly metabolically active plaques would light up and so identified as vulnerable. Then there was something called pulpography, where they used ultrasound analysis just to get some assessment of the mechanical properties of plaque. But also I haven't seen in years anymore. FFR obviously came about to look at flow or limiting disease. But nowadays also there's some suggestion that FFR is connected or identifies vulnerable plaque by extension. And more recently, there is a growing business focusing on software, particularly non-invasive software, to identify vulnerable characteristics. So there's no doubt that there's a lot of business interest which will contribute to the fact that this concept will not go away. And I'm not criticizing this. As I disclosed myself earlier, I have industry connection as well. I work with industry. We need industry, but whenever there is obviously industry involved, we have to be very mindful of the potential conflict of interest. Okay, so now let me review a little bit about why I believe that Steve Nissen is right, that the concept of vulnerable plaque, the single vulnerable plaque, is fundamentally flawed. And essentially, it comes down to two fundamental observations. Number one is, and we know that from pathology studies, that there is ample of evidence that plaques rupture frequently without causing symptoms. And so this is an observation going back to the 1990s, made by the amazing pathologist Michael Davis. So this, for those who don't know him, and he died actually almost 20 years ago now, prematurely. He was a phenomenal pathologist, cardiac pathologist in London. And he wrote extensively in the 1990s about acute coronary syndromes and vulnerable plaque. And he was one of the first, probably the first, I'd say, recognizing that many in his autopsies of patients dying of non-cardiac causes, there was evidence for plaque ruptures with no association with any clinical events. Okay, so a few years ago, we went through the exercise summarizing that evidence. So you see here a table with the numerous studies. you see the mode of assessment, pathology versus imaging, most of them IVIS, more recently OCT. And then what's shown here is the total number of patients broken down to whether they were stable patients with stable corneal disease or even normal controls here indicated by an asterisk, or ACS patients. And then you see the percentage here in the next column behind it of non-corporate plaque rupture. So these are plaques which are not associated, with the initial presenting event. And what is clear from this is that, that there's a percentage, a fairly considerable percentage of patients even among normal controls. So these are normal controls, patients dying of non-cardiac causes. And depending on the risk of the population, between 17 and 31% of those patients had evidence of plaque ruptures in the coronaries, again, without any association that there was any clinical event associated with these lesions. Now, if you look at IVIS, IVIS is much less sensitive to detect plaque ruptures. The numbers are lower. OCT, there was one larger study with OCT. Here you see the numbers very closer to pathology, about 17%. So, again, you have to also remember that this is an underestimation also, because not all plaque ruptures, are easily detected, even by pathology. I'm going to talk about this in a second. So I think it's fair to say that roughly at least 20% of patients, if you just pull them from the street, will have evidence in the coronary tree of asymptomatic plaque rupture. It's a huge number, obviously. It kind of indicates that this is a very frequent phenomenon. If you look at patients with ACS, the number is much higher. So indicating what we know now, that an acute coronary syndrome is a reflects a pan-inflammatory process. With the numbers of non-corporate plaque ruptures, being easily in the 50% range. Okay, so we can take from that there is strong evidence that non-corporate plaque ruptures are found frequently in patients, irrespective of or non-related to clinical events. The other key observation, again coming from pathology and actually also coming from Michael Davis, is that if you take any random lesion in the coronary tree, and so he did a systematic analysis of any 50% or greater stenosis in the coronary tree by autopsy, you will find in the vast majority of them evidence of prior plaque rupture in that lesion. So it's shown as an example of collagen here growing into that gap, which was caused by a plaque rupture. And yet, this lesion is intact now, but there's evidence that there was a prior rupture. And again, this is an underestimation, as he clearly pointed out in his paper, because if the gap completely fills, it's very difficult to kind of know that there was a gap before. So he found more than 70% of those stenosis containing healed ruptures, assuming that the vast majority of those plaques actually had prior asymptomatic ruptures. Okay, other pathologists confirmed these studies and came up with the hypothesis that any lumen growth in the coronary tree, so shown here is the new lumen versus the old lumen in percent, is essentially the result of not just one, but often 2, 3, or 4 ruptures in the same plaque, which then leads to that high level of lumen obstruction. Now, we were lucky enough to have a beautiful example of several plaque ruptures in the same plaque. So this paper, we collaborated with Renu Vermani, and she was kind enough to give us this sample, histology sample. And what you see here is evidence of 3 prior ruptures in this plaque, 1, 2, and 3. And yet, again, this is an intact plaque. There's no rupture, there's no erosion. This is an intact plaque. It had nothing to do with the patient's cause of death. And there were 3 distinct ruptures prior in this plaque. So we were lucky here. typically these gaps close and you wouldn't know. But so we had like this fortunate circumstance that these plaque ruptures occurred in time such that they didn't have time to close. So it's a really nice example of several prior plaque ruptures. So these two observations, again, are the key undermining the significance of the vulnerable plaque. As asymptomatic plaque ruptures are found often in patients without ACS, and most advanced lesions have undergone prior asymptomatic plaque rupture. So if you think about this, knowing how common lesions are, autopsy studies from the Mayo Clinic showing a middle-aged man dying of non-cardiac causes, 9% have obstructive lesions. So we're talking about millions and millions of people. Some people even believe, which is still not well proven, that any kind of calcification in the coronary tree is the result of plaque healing after a rupture. So the point here is it is exceedingly common for plaques to rupture and heal. And in fact, I think it's well supported to conclude that is the default consequence of a plaque rupture, that plaques initially grow by the common mechanism of cholesterol inclusion in the plaque growth, inflammation. But after the initial growth, that fairly early in the process, the plaque tends to rupture and then heals, and then ruptures again and heals, depending whether the atherosclerotic process is being propagated or not. And in fact, that the chance that you have an acute coronary syndrome is small, and essentially is the aberration of the process. It is the exception to the process. Obviously, they do happen, but something seems to go wrong, that it does not lead to asymptomatic healing, but it leads to partial or complete occlusion of the vessel. So what goes wrong? That is the million-dollar question. What is it? What causes this process to go in the wrong direction? And we don't know. So what we believe and hypothesized, prior is that it largely comes down to the blood vulnerability at the time of the rupture. That in the normal situation, the plaque heals because the thrombosis resisting factors outweighing the thrombosis promoting factors. But under circumstances, the system is overwhelmed. There are more thrombosis promoting factors and overwhelming the defense, so to say, which then leads to more widespread thrombosis. So a concept which particularly I feel like is neglected by cardiologists is that it seems like the key issue is not so much the plaque. Obviously it is, but the key issue is how the host responds to the plaque rupture. So it's more about the blood than the plaque. So simplified, an acute coronary event risk is the interplay, the result of the interplay between the thrombogenicity in the coronary arterial tree, which is driven by the plaque burden, plaque characteristics, etc. But more importantly, the vulnerability of the blood. But the issue is that the blood vulnerability is exceedingly complex. There are gazillion factors driving the blood vulnerability, and many of them are known to us. Obviously, overarching thing is inflammation, and inflammation is driven by a lot of factors. And we see here the typical risk factors: diabetes, obesity, smoking, and these are all risk factors. Not only they contribute to atherosclerotic disease, but importantly, they're all prothrombotic factors. So they're contributing to a inappropriate response of the host to the plaque rupture. And many of those factors are in flux. They're not just static. For instance, there's a circadian aspect. I'm going to highlight in few minutes. And then there's diet. The diet is not just a factor per se, but it's also a factor minute to minute. There's good evidence that if you eat a fatty meal, that your lipoprotein levels change and your coagulation factors change. So there's a minute to minute variation of our vulnerability. So the picture, which arises, at least, to us, is that the result, the acute event, is essentially as a perfect storm. That in the moment of the plaque rupture or the time of the plaque rupture, the system, the host, is vulnerable to allow widespread thrombosis. Having said that, a storm, there's obviously models to predict a storm. It's hardly ever perfect because of these varying factors, but there are at least three categories of factors which are driving that risk. And for one, for sure, it is the atherosclerotic disease burden, so which we try to summarize in this paper. We took 3 data sets, one from the VA database in high-risk patients called the cath lab, one from CT, angiography, that like mid-range risk patients, and then there's a lower risk patient, calcium scoring asymptomatic patients. And they're all showing here the risk of MI or death, so the heart events in percent, annualized risk in percent, versus the atherosclerotic disease burden, which is shown here in a semi-quantitative fashion, so between or ranging from no disease to varying degrees of non-obstructive to 1, 2, or 3 vessel obstructive. And here similarly, no disease, limited non-obstructive, extensive non-obstructive, limited obstructive, extensive obstructive, and here just the calcium score. The point of this is they all show the same thing. They show essentially a linear relationship between how much plaque you have and your risk. And indeed, actually I took another sample a few years ago from calcium scoring and I plotted it, in a linear regression model. And you see here the relationship is remarkably perfectly linear. It's really incredible that the strength of this relationship. And importantly, there's no threshold. It rises from the smallest amount of plaque you can detect up to the highest level. So we've been for years so obsessed with obstructive disease or ischemia producing lesion. There's no evidence that there is a threshold effect. It's a linear relationship, and more data coming out now to support that we've been neglecting a lot of patients because we were so focused on high-grade stenosis and ischemia-producing lesions that we now only detecting or we're recognizing that the risk is a risk continuum. And it's just nicely shown here. Okay, so that is very well established. And the other component here is plaque progression or progression of atherosclerotic disease, which is also well established. This is from the calcium score data again. Survival, this is a total mortality. They did a CT at baseline, and a few years later, those who progressed with atherosclerotic disease had a substantially greater mortality compared to non-progressors. So, which makes sense. These things make sense. But if you have more plaque, not only more plaque means that you have more plaque ruptures, and the more plaque ruptures you have, the chances increase that one of those plaque ruptures coincide with a vulnerable state of the host. Similarly, if you have progressive atherosclerotic disease, you also will have more turnover, more plaque ruptures, more plaque erosions. Similarly, you will have an increased risk that you will have hit a vulnerable state with one of those plaque ruptures. So largely, it's a somewhat stochastic principle. And then, as mentioned, the third big component is the blood vulnerability, which is the most difficult, I'd say, because again, there's so much variability. Yes, here I'm just showing very old data We've been known for a long time that there's a circadian pattern of AMI risk, peaking in the morning hours, which coincides, with a weakness or low point in our coagulation systems. Also there's some changes in the catecholamine levels. Again, highlighting that there's so many variables, all kind of contributing to our vulnerability, the blood vulnerability. So that's why, we believe that the perfect storm, these three, atherosclerotic disease burden, disease activity, and prothrombotic, these are the key components of driving the risk. And we lately labeled this as a triangle of ACS risk, the burden, activity, and the prothrombotic milieu. Okay, so with that, I think the point is hopefully well supported, that if that's true, that a single vulnerable plaque, is not of much significance. If most of these plaques rupture asymptomatically, if you identify them, it doesn't make much difference, because again, most of the time they heal anyway. Moreover, even if we find them and then do something about it, something interventionally, the probability that you hurt the patient because of the risk associated with the procedure is likely outweighing that very, very small benefit of doing something to that plaque. And that has really panned out in those studies where they try to preemptively stent. But still the question is, why, are there so many studies claiming prognostic value for vulnerable plaques, giving these discussions? And there are so many studies, and almost every week there's a new study coming out and saying, well, there's clear evidence here that these vulnerable plaques are predictive. So the two major issues which I feel most of those studies have is that, for one, that the major adverse cardiovascular events they're looking at are not heart events, and they're often revascularization procedures, which is a completely different mechanism. And so you have to make sure that we're actually looking at ACS in terms of predicting outcome, because this is, again, otherwise we'd be introducing a complete different mechanism in here. And the other factor is that often the prediction of vulnerable plaques is confounded by plaque burden. So there are many studies saying, well, the vulnerable plaque clearly predicts outcome, but without accounting for the atherosclerotic plaque burden, a vulnerable plaque often is just a marker for atherosclerotic disease. And I'm going to show you examples of that, but I think these are the two major problems. And so I encourage you, if you look at vulnerable plaque papers, just to look for these two issues with these papers. But let me just go briefly over some of those big studies. With the PROSPECT study is the mother of all vulnerable plaque studies, but a lot of attention was published in the New England Journal of Medicine, and you see the results. And you probably remember that they took about 600 patients after an ACS treated with stent, and then look at the non-corporate lesions in these 600 patients, followed them for 3.5 years. They studied them with the virtual histology, intravascular ultrasound, and they found about 600 vulnerable plaques, thin cup fibroatheromas, TICFAs, and then they kind of looked what happened and tried to associate the presence of the TICFA with the outcome. And as you probably remember, they show particularly this slide, which illustrates this is the rate of MACE according to the plaque type, and they showed if you have a TICFA, a vulnerable plaque, compared to all other plaques, you have a much greater risk of MACE. And if you have a TICFA which actually has a small residual lumen, even greater. And then if you have one with great plaque burden, even greater. And if you combine them, you have an 18% risk of MACE compared to a very small risk compared to other plaques. And that looks very impressive. That was the message which went out. The issue with that is if you look at the actual events, these MACE, death from cardiac causes, there was 0. Myocardial infarction, there were 6 patients out of 600 had an MI. So these events, they were almost all of them were hospitalization for angina. And mind you, not acute coronary syndrome, because if they had a troponin elevation, then it would count it as a myocardial infarction. So these are presentations for chest pain. And if you look at with these knowledge in mind, a thin cap fiber atheroma is associated with greater lumen narrowing compared to other plaques, even shown in this prospect study if you look at the appendix. And with that, obviously, if you compare plaques which have a baseline greater lumen narrowing compared to other plaques with less lumen narrowing, it is clear that the plaque which has greater lumen narrowing at baseline is more likely to increase in terms of lumen stenosis sooner to a degree that will cause angina. And even more so if you have a plaque which already has small lumen narrowing and has like a large plaque burden. So essentially what the prospect study showed is that if you have plaques which have a greater baseline lumen narrowing, that they are more likely in a few years to be associated with angina. Had nothing to do with predicting ACS. Indeed, when we actually plotted the thin cap fiber atheroma risk annually, we usually think an annual risk, and we just looked at the hard endpoints, death and MI. The risk of a TICFA in this prospect study was very, very small and not really different than even an intimal thickening found on IBIS. Really substantially less than high risk. So if you really scrutinize the prospect study, it showed essentially proof to you that the identification of vulnerable plaques really did not have any impact on patient management. There are several studies, there are many studies, and it's really a moot point just to go over them, all these studies which essentially are flawed with the same issues. I want to highlight briefly that the field lately is shifting more towards plaque healing than plaque rupture. There was a paper last year which got a lot of attention by OCT. You see here fibrous plaque, lipid plaque. OCT is a great tool. And showing here plaque healing. And in their study, they observed that those patients who had a recurrent ACS, that they had a much lower percentage of healed coronary plaques compared to patients who had stable angina and no recurrent or no problems, or patients who had an initial event and then had no recurrent events. So there was another study actually showed the opposite, where they looked at also OCT, and they found that those patients who have an untreated healed plaque had a higher event rate compared to those who had no untreated healed plaque. So I'm not quite sure what to make out of this, the very contradicting findings. So the author of the prior study actually published this recently in the New England Journal of Medicine, suggesting that that there may be something like a two-hit or there's a two-hit hypothesis, where initially you have a plaque rupture or erosion, and then if you have effective healing, you have a chronic syndrome. But if you have a second hit, so to say, when you don't heal effectively, then you proceed with ACS. I have to say, I didn't find this hypothesis well supported. I still, an alternative explanation of the findings, I'd say, is that if you have a patient who, again, is not very vulnerable in terms of his blood, you may have lots of healed plaque ruptures, but they're inconsequential because the patient is just very resistant to thrombosis. And we have to keep in mind that most patients, when they get older, they have atherosclerotic disease. And many, die and have never had a myocardial infarction in their life. So again, it comes to me a lot more down to the propensity of the host to respond to the plaque rupture in different ways. All right, so now let me, I have to kind of speed up a little bit when I get through this, because now we get into an aspect which is actually really exciting, which is a little different than we talked before, because before we talked all about invasive measurement, now we're talking about non-invasive imaging of high-risk plaque, which is obviously very exciting because we can image broad population. And initially, they followed the same kind of concept like the IVIS studies. They looked at high-risk single plaques. There was a study by Motoyama, got a lot of attention, and showing here that the cumulative event-free rate, is greater, with if you have no high-risk plaque versus high-risk plaque. But the problem here again was you comparing high-risk plaque versus non-high-risk plaque. That also means that you're comparing high-risk plaque versus no plaque. Yeah, if you have no plaque, obviously you're very low risk. What you have to compare is the same kind of plaque with high-risk features versus the same amount of plaque, without high-risk features, which is part of the confusion. And in fact, if you look at the paper more detailed, they actually did a follow-up scan. They looked at plaque progression and they did a multivariable model. And if you look actually the factor, the hazard ratio for ACS in this study, which was the highest by far, plaque progression, blew everything out of the water. Extremely high hazard ratio. So again, pointing to the fact that the activity of the plaque is a major factor, whereas the high-risk plaque, whether it was in CT1 or 2, essentially was not really significant, and other factors, even BMI, were more important. And again, there are also a number of studies that like that have the same issues. Now, I want to though now spend some time on some more interesting aspects of that whole concept, which goes to leaving the single vulnerable plaque behind and focusing on high-risk atherosclerosis. So this is not the same. The single plaque theory is essentially, I'd say, dead. There is nothing to support that. But now that we are able to quantify entire atherosclerotic disease burden by CT, now the question arose, well, is all plaque the same, or if the composition of the plaque is different, does that have an impact? And and that's part of from our laboratory. So obviously there are lots of softwares out now tracing plaque burden, which is an exciting development. There are lots of studies out there. Again, I want to highlight one study which I feel is one of the best out there because it addresses the two issues which I mentioned earlier. It does use heart events. So this is only death or actually fatal or non-fatal MI, which is a strong point. They used the Scotthead trial essentially for this. And the other thing is they accounted for the overall plaque burden when they looked at what they feel is high-risk plaque burden. So this is a well-done study by Michelle Williams and others. And if they look at here at those patients who had events versus not, and again, these are hard events, clearly the more plaque you had, or I should say those who had an event had more plaque burden, they had more non-calcified plaque burden, they had more low attenuation plaque burden, and they had more calcified plaque burden. Consistent with that paradigm, the more plaque you have, the greater your risk. Now, unfortunately, they also showed something like this, again, where you said, all right, if you have less than or equal to 4% of low attenuation plaque, which is low attenuation plaque is the new kind of vulnerable plaque everybody is excited about, versus greater than 4%, you see there's a clear difference. Again, the problem here is you could have shown the same thing for the total plaque burden or calcified plaque, would have shown all the same thing. So that's not really a fair way to portray it. But she did, or they did, I should say, use a motor variable model here to see whether there is what drives the risk. And at baseline, all of those plaque burden metrics are associated with worse outcome, notably calcified plaque burden doing, it looks like, better than overall plaque burden, which doesn't make any sense. Plaque burden obviously encompasses both calcified and non-calcified plaque burden. But if you use the multivariable model, they say, well, see here, this is the only one that's statistically significant. Well, so the way I see this is that there may be something to the story that if you have plaque, which has particularly more, low attenuation plaque, non-calcified plaque, that they may be more metabolically active. There may be something to the story. I would still caution, though, that something of this may be the way it's computed. These are all basically by doubling the volume. And if you have a very small volume, like attenuation volume, there may be some effect by the way, it's computed, because it's much harder to double your plaque burden, but it's very easy to double your low attenuation plaque burden. So there may be some, that may also explain the weird kind of hazard ratio, which, again, don't make much sense to me, why the overall plaque burden should be lower than the calcified plaque burden, etc. But the bigger point is, that incremental value, if there is such thing, is very small. And the question is really, what are you going to do about it? We know that the plaque burden drives the outcome, and we know, essentially what to do, but there is no evidence that there's really, any actionable evaluation management strategy. If you have this may come. So I'm still being cautious, but I'd say the problem, with these kind of analysis is that we kind of like losing a little bit the sight for what is really critical. And what's critical is to detect atherosclerotic disease, and it really is of secondary importance, whether it's low attenuation, calcified. The key thing is we need to detect atherosclerotic disease. And that's where actually we're failing right now, because currently the vast majority of our evaluation of patients with chest pain is with stress testing. We summarized here data from Promise, Scotthard, in a large Danish registry, the outcome of patients undergoing CTA versus stress testing. This is study size, medium follow-up, and this is non-fatal MI, and this is death or MI. And all of those studies, showed a risk reduction with CT versus stress testing. Promise trial, you would at the shortest follow-up, it was a little modest and not even statistically significant. But if you went out a few more months, it was statistically significant. And when you went out further in the Scotthard trial, 40% risk reduction for MI. So the frustration is that we're looking for this vulnerable plaque, vulnerable atherosclerosis, where just right in front of us, we have the opportunity every day to reduce the risk of myocardial infarction by 40%, over that time period. So this is incredible. This is unbelievable, and we're not using it. We're still using a test which is archaic, which looks at atherosclerotic disease at the end stage, essentially a late stage where it's causing hemodynamic significance, etc. What we really need to do is we need to, as soon as we can abandon the stress testing paradigm, and any patient comes with chest pain needs to have an assessment of atherosclerotic disease. That is the key thing, and that's where actually saving lives, or particularly, I should say, myocardial infarction, that is right in front of us, and that should be our focus. We're proposing now to this algorithm, which was recently published, which doesn't require quantification of plaque. All what it does is just like saying, well, you have no plaque, you're good to go. But if you have, non-obstructive disease, which is limited, you need medical therapy. But if you have extensive non-obstructive disease, there's more and more evidence to support that there's essentially same risk as high or obstructive disease. You need intensive medical therapy, lifestyle interventions, in reserving revascularization for high-risk patients, with low EF or multivessel disease and diabetes, etc. Okay, so I'm almost done here, but I just want to also close. Obviously, there are some other exciting things in development, particularly highlighting the component of plaque progression, inflammatory activity. You heard about perivascular fat inflammation, which is something many are excited about, and showed that it makes a difference in terms of outcome, and even adjusted for plaque burden assessment to some extent. Haven't really seen much lately from this we tried this in our laboratory, not being as successful, so there's a little question mark about it, but the whole concept is obviously very intriguing. And then another development which we are excited about is ultra high resolution CT, which means that the slice thickness with this ultra high resolution CT is down to 0.25, which is a big jump. This is not like some vendor gimmick. The smallest slice thickness so far out there is 0.5. This scanner is 0.25. So it's doubling the spatial resolution. You see here conventional CT, a lot of calcium, which is hard to tell what's going on. And the ultra high now shows that there's actually a lot of lumen here. And it was called non-obstructive, in contrary to the conventional CT. And the cath actually confirmed that it was not obstructive disease. Okay, so let me conclude. I believe the concept of the single vulnerable plaque is fundamentally flawed, and a substantial body of evidence contradicts the idea of value by identifying and treating such plaques. The risk of ACS is largely mediated by the burden of coronary atherosclerotic disease, its metabolic activity, and by the host's vulnerability to thrombosis, and a potential role of differentiated plaque volume quantification for advanced risk stratification is under investigation, but its impact, at least I believe, appears to be small. But most importantly, a substantial immediate impact for ACS reduction can be achieved by detecting coronary atherosclerotic disease in symptomatic patients instead of traditional ischemia testing. Thank you again for the opportunity, and I'm very happy to address questions.
That was a great talk. Thank you so much. That was outstanding. Let's see if Dr. Garcia.
Hi, Armin, that was fantastic. Thank you so much for giving us your perspective on so many issues, and particularly the one that is so important about the vulnerable plaque and the debunking of the concept. So I had two questions for you. The first one is, if we really don't need to be looking at individual plaques, but rather burden of atherosclerosis, why do we focus on imaging arteries that are very small and don't go to vascular beds where the arteries are larger and easier to measure? That's the first one. And the second one is more of your opinion. Is it any role in 2020 to do ischemia testing?
Yeah, so thank you, Mario. It's great questions. I believe that the association of coronary atherosclerotic disease and peripheral vascular disease is not as close as it's widely perceived. To be honest, I cannot quote you specific studies. I have to dig them out, but I also from personal experience, I see it all the time that folks have extensive coronary atherosclerosis and very little, disease, in the carotids or, peripherally, and vice versa. Patients have extensive atherosclerotic disease peripherally, very little disease in the coronaries. So, and then the thing is, it's so easy now to do coronary imaging. If you don't want to do CT angiography, you can do a calcium scan. There's actually more and more evidence but a plain calcium scan, maybe all what we need. I don't want to say that because it undermines my own operation, but there is some paper actually coming out next week, which highlights that the calcium score is such an easy, cheap way of showing atherosclerotic disease. In many cases, that's probably all what we need. Now, in terms of ischemia testing, is there a role? My personal belief is there's a niche role for certain circumstances where you really kind of don't know, whether these symptoms are really due to angina or not, and maybe you want to kind of prove that there is ischemia. So there is a role, but I personally feel that the role is small. But most circumstances, I think the patient's history should drive if the question is symptom relief, and otherwise the outcome of patients is driven largely by, or the heart outcome I should say, by the coronary anatomy and also by LV function.
That's great. I think we'll move with some other questions. I have one question first, and I think so the calcium score, it's great to quantify plaque burden, and that's why I personally do it in most cases. So in that way, you don't only give a percentage of stenosis, but you also give a burden. I think that's very useful for the referring doctors as well. But what about soft plaque? And should we be using more like total plaque scores? And I know there's some work by Brian Coe with incorporating FFRCT as well into this. What do you think about these advanced scores for?
Well, I think what they have to prove is that they have incremental value. So at this point, I don't really see now how the measurement of soft plaque, the non-low attenuation plaque, and all these things, how they really change the management. And from what I looked at is that their incremental value, if anything, is very small. So at this point, I'm always thinking very pragmatically. What I'm going to do differently. So if there is no information, first of all, there's no evidence from studies that information will change management and will change outcomes. So there's a long way to go for these. So at this point, I don't see much justification to do this. I think the key thing is to keep it simple and do what you actually can every day easily, which is identify the atherosclerotic disease burden, and then for the future maybe there is additional value and not. I think they've proven the burden of proven is on these additional metrics to see whether they can clear that bar. Now, in terms of CT-FFR, I personally see CT-FFR similarly like I see any kind of functional testing. I see the role is limited, and it's additional cost to the patient. You always have to look at the immense cost we currently burden our healthcare system with, and then I don't see that CT-FFR adds anything in terms of patient outcome and management, and it costs a lot of money. It does cost a lot of money. So I personally don't use CT-FFR at all. The other issue is that I feel like CT-FFR doesn't work well in calcified lesions, and often in those lesions where I really want the information or may want, it doesn't really work that well. There's some other studies showing that compared to more advanced CT assessment, there is actually not much greater accuracy in predicting flow-limiting disease. These validation studies for CT-FFR were mostly done compared to very simple 50% diameter stenosis, where when you actually try a little harder by CT, regular CT, you're getting pretty close to what the CT-FFR does.
Okay, thank you very much. I think we have some questions coming in. First, they will send by email the code for the credit, for CME credit. There was a question about. There's a question from Suraj Dahal, is the first one that came, and just touching about FFR as well. Can you please highlight on why FFR concept is not valid and does not match with plaque burden?
Well, so the CT FFR concept is based on that we have to identify flow limiting disease. And essentially it kind of gives the category, either it's abnormal or normal. And we kind of dismissing, with the FFR, the disease which is not flow limiting. But all the evidence shows that, there's a risk continuum, that any plaque matters. Now, if it's 50%, even though it's not flow limiting, that means that the patient is of increased risk. So the ischemia trial obviously showed that even if you revascularize all those flow limiting lesions, you don't gain anything in terms of outcome. The FAME studies, I believe, are, to some extent skewing the picture. For one, the initial FAME studies did not show any reduction in hard endpoints. The only thing which showed in the FAME2 study was that you had less presentations to providers, but there was no difference in death at MI. There was always now the quoting that there was a 5-year follow-up showing a borderline significant lower rate of MI in the FFR arm, but you always have to also keep in mind that the intervention arms are always getting dual platelet antitherapy, which lowers your MI risk, which was an issue actually also with ischemia. Whenever you have PCI versus medical therapy, the patients in the PCI arm getting dual antiplatelet therapy to a much greater degree, and DAPT decreases MI risk. There's no way about it. So basically, I'm saying there is really not good reason to use CT FFR if you are interested in improving a patient outcome. In the opposite, I would say in the contrary, you're more likely to dismiss a patient who has a FFR value less than or greater than 0.8, even though he has a lot of atherosclerotic disease. So our mindset needs to adjust. That is really the atherosclerotic disease, which we have to keep our focus on.
Okay, great. Another question from an anonymous person says, beyond baseline plaque burden, given that plaque progression connotes a very poor prognosis and that longitudinal medical therapy studies with statins and icosapentaethyl demonstrate a transformation of plaque composition, non-calcified to calcified reduction to high-risk plaques, etc. Should we be using serial CT imaging to guide intensification in medical therapy to treat atherosclerosis rather than risk factors? I think coming with Dr. Budov data. I don't know if that was him, but.
Well, so it's a great question. But the question we always have to ask ourselves, when we do anything is, what will we do differently? Yeah, and the thing is, we are doing poorly with our medical management. There's lots of data showing that our medical management is far from optimal. So there's lots of studies showing, for instance, that even clinical trials, that if you just get to the simple goals of blood pressure, blood glucose, smoking cessation, and cholesterol control, all 4 of them, the less than 20% in Courage and in the Freedom trial were at goal after 1 year in clinical trials. Even in the ischemia trial, it was barely 40%. So it means like the majority of patients are not treated. So what we really have to focus on is just like to treat our patients better and get them to goal. So there needs to be a lot more emphasis on secondary prevention. So, so back to the question, what are you going to do differently if you show, after 2 years that there's plaque progression? There's not going to be anything different. You just try hard, and what you should try hard to begin with. So there's always the issue that we kind of like to do more imaging and more looking harder, but we always have to ask ourselves, what is the impact? What are we going to do about the imaging information? And I don't see much, we would do differently by repeat imaging after a few years.
So you wouldn't jump into more medications. I guess the concern is, should we use all the tools for every patient, or should we just try to select the highest risk from this progression to use more medications, or Xarelto, or?
Well, again, we should have, used everything to optimize the patient anyway. If there is a question that you are not sure whether the patient falls, in this category versus that, maybe then there is a role. So let's say the patient initially had, stage 2, what we consider stage 2 coronary heart disease, meaning like mild non-obstructive disease. Now, and you would not treat him as aggressively. And if you then, a few years later, you want to see whether the patient needs to be more intensified in terms of management, maybe then there's a role like, all right, let's take another look if the disease has, accelerated, etc. So there may be a role in select patients, but again, the key question is always, how does it impact, our management?
And probably how accurate I would measure the progression, right? That's something, if you're going to change your management based on progression, you want to be very accurate in the measurement, right? Yeah. Okay, a question from Ethan Goldberg, one of our faculty. In the past, we used physiologic testing to diagnose CAD and anatomic testing to make decisions on revascularization. It seems that we should be doing the opposite: anatomic tests for diagnosis and physiologic tests to guide treatment. Not really a question, just curious to hear your comments.
Well, sort of, yeah. So I believe that the evidence suggests that we need to guide our management, mostly by anatomy, and the functional component is mostly to the question of symptom control. That is because it's important, obviously an important component. We want to make sure our patients, are well controlled. The issue is that most patients don't have bad angina. That's something, from our practice. First of all, typical angina is fairly infrequent. Most patients have atypical symptoms. The PROMISE trial showed almost 80% of patients have atypical symptoms. And in our recent, JACC paper, we summarized, from several databases, that the vast majority of patients with stable coronary disease have very mild symptoms. So even in FAME2, patients with class 3 angina or class 4 angina, were less than 20%. So these are highly selected patients, obviously with FFR positive, etc. So most patients don't have bad symptoms. In the schema trial actually also showed that. So I think the key emphasis is we want to make our patients live longer and making sure we control the atherosclerotic process. That is the key goal. We have to halt the process and mitigate the factors which lead to a heightened risk of an abnormal response to the plaque. Controlling the prothrombotic factors. That is the key. And in addition, the symptom control is important, but I feel it's a step down in terms of the significance. So it's not like we're trading one versus the other so much. I think it's mostly about the anatomic disease and secondary about its functional significance.
I think trying to link with some other questions. I think Mark Dweck here is asking, is the type of plaque that you measure burden important? In example, better to measure the burden of non-calcific or non-attenuation plaque versus calcific plaque, and also sodium fluoride, for example, just linking with Mark.
Yeah, so I don't think there's much evidence to support that we have to kind of choose one versus the other. So the key thing is how much plaque there is. Is there plaque, and how much plaque there is? These are the key two questions. Whether there's additional value in plaque differentiation, I think it's undetermined at this point. I think there's no evidence that there's benefit of different management. We're not that far anyway. But there's conceptual evidence saying like, well, if you have more non-calcified plaque or attenuation plaque, that potentially, is a marker for more active plaque. But again, I think the incremental role of that assessment appears to be small. And so we're getting sidetracked, with these questions, and I think we kind of losing the sight of what's critical. The critical thing is measure plaque. That's what we're not doing that. We have 10 million patients coming to us with chest pain every year, 10 million, and the vast majority of them get a stress test and then sent home. Where we're missing the opportunity. If you do the math in those, and just looking at the data from PROMISE, that about 80% of stress tests are normal, and looking at the same kind of event rates in PROMISE, because PROMISE was done in the US, it's very representative. Then we're looking at, we could save as many as 17,000 MIs every year by using CT. Because the CT, we detect patients with atherosclerotic disease, we put them on aspirin statin, and using the data which is out there, he's saving 17,000 MIs every year, using the CT versus the stress testing approach. I think that is, the problem is it's economical issues. The CT is not good for business. The stress testing is, particularly nuclear. So there's a lot of political issues, etc. But from a science and public health standpoint, that is what we do, and we have the biggest impact if you do that.
Yeah. So from Alan Kwan, in the past, he says we've been more limited in our therapeutic options with medical therapy, just limited to aspirin and statin. With recent expansion to PCSK9 inhibitors, LPL-A targeting now, and inflammatory targeting with canakinumab, and more antiplatelet medications. He asks, do you think there is a specific framework to target the different parts of your proposed triad within an individual patient? Or do you think that medical therapy will always be overall risk-based, not personal physiologic-based?
No, it's a good question. So the time will tell. Eventually we may be able just to tease out that there are specific characteristics which we can tailor our medical management more finely to. You're absolutely right. Our armamentarium of medical therapy is getting bigger and bigger and bigger. But at this point, we don't know. We just don't have the information that allows us to say this patient will benefit in addition from this. So we have a lot of work to do. So it is conceivable that we have finer tools, that you cannot say, well, this patient may benefit from that or not. I'd say, again, from my estimation, is that these additional information, are of smaller importance. That the key things are the plaque burden. How active the plaque is, and particularly the risk factors. And again, we're doing so poorly. We're doing very, very poorly in this regard. So there's a lot of things we can do right now. But there is the potential that eventually we'll be fine-tuning our evaluation and management. That's right.
Yeah. Okay, so I think the last question from one of our imaging cardiologists, Vikram Ramanandam. This really excellent talk. Do you anticipate a growing role for imaging vascular inflammation, either by CT or MR, given we have seen evidence for the use of, again, canakinumab or colchicine for reducing events in CAD?
Yeah, thank you. Yeah, I do think particularly the potential to look at inflammation by imaging, I think it's very, very intriguing, because that is the component, which was essentially lacking in terms of our assessment. Plaque burden, you can assess at least, reasonably well risk factors, not all. There are a lot of factors we don't understand in terms of the thrombotic state. But the big thing which we are missing is the to know which plaques are going to progress more rapidly, because when we talked about doing repeated imaging or serial imaging, but it would be much more desirable, obviously, just to have some information and baseline, knowing that this plaque is going to be progressed more rapidly, and then inflammation is one component of that, which may point us in that direction. And we are actually, when we saw the data for the perivascular fat attenuation as a marker for inflammation, is extremely exciting. So there is a lot of, and it seems, I heard this is in FDA approval right now, the assessment. So yes, I believe there's going to be a lot more assessment of non-invasive assessment of perivascular inflammation, and we'll see how that will pan out with our fine-tuning our management.
I think just to finish, a question actually from Dr. Budov now is more intriguing. So what about the role of atherosclerotic phenotyping to understand the vulnerable patient and guide appropriate risk stratification trials and treatment? I guess that's a summary of what we're saying.
Yeah, so I mean, I think that's what we discussed in terms of phenotyping, looking at plaque characteristics, differentiated plaque, the low attenuation plaque, calcified plaque. And so there's a lot of excitement in the field about this right now. I mean, what I said is like that at this present time, we don't have evidence that there is much really incremental value over the overall plaque burden assessment as discussed, and B, we certainly don't have any evidence that that there is additional management options which are effective in addressing these findings, even if we detect them. So I mean, again, there may be in the future that we have the evidence that there is incremental value, but right now we don't. There is not such evidence, and again, I think the key thing is just to focus on what we can do right now in clinical practice, which is detecting coronary atherosclerotic disease in the many patients we see now.
That's great. That was an excellent talk. I think the discussion also got excellent, and I'd like to close with what you said. There's a lot of work to be done, a lot of therapeutic opportunities, and a lot of imaging options. So I think it's a lot more to do to help the patients, right? Research. Yes,
that's the key message. We can go to a clinic now, and patient comes with chest pain, and we are inclined to order stress test. Don't do it. Order a CTA.
Okay, great. Thank you so much for your time.